All right, thanks for having me here. We're going to talk about preeclampsia. It's a topic that is near and dear to me. So we'll just go over first the objectives. I want to review the current guidelines for preeclampsia. This will be a review for all of you and what the diagnosis is, and then briefly go over the current mechanisms that we know of for preeclampsia. And then I also want to touch on the distinction between early and late preeclampsia, which is something that is starting to be delineated in those researching preeclampsia. And then we'll review some algorithms for trying to predict who is going to get preeclampsia. And then we do have some recent changes in how we're managing preeclamptic patients, which is going to be important for us as we're taking care of these patients during their labor and during C-sections. And then I just want to touch on the current treatment trials that are underway. And we'll just end with discussing some long-term effects of preeclampsia. So let's jump in. The effects of it affects about 5 to 7% of the population, and this actually has been rising. And it's interesting that I'm following after the obesity discussion because it is rising as obesity rates are rising. And you can see there with the risk factors, the couple that I wanted to point out are the pre-existing hypertension, extremes of age, diabetes, and obesity. So as the diabetes rates and obesity rates are increasing, we're seeing more and more preeclampsia. So what is preeclampsia? This is all pretty much review for you guys. It's hypertension with proteinuria. That in order to meet the diagnosis, you have to have a blood pressure of 140/90. You have to have 300 milligrams of protein in a 24-hour urine collection. And then to meet the diagnosis of severe preeclampsia, you have to have one of the following listed there. And we can add also IUGR to that. So any one of those various factors will put you in that category of severe preeclampsia. So pathophysiology. This is actually millions and millions of dollars and years of research has been put into trying to figure out what the pathophysiology of preeclampsia is. And sadly, we still don't have a complete understanding. I'll review the basic, what we do understand at this point, and that'll be a good jumping point for what we're using for certain treatment trials now. So there's a poorly understood placental process. We always hear about it being a dysfunction in the placental maternal interface, and that's the asymptomatic part. That's the part that we don't see. The patients look like they're moving along in their pregnancy fine, but it's hypothesized that what's going on at the placental maternal level is there's an ischemia and hypoxic event that happens at the placenta, and you get shallow invasion of the trophoblastic tissue and insufficient remodeling of the spiral arteries. So what that leaves you with is essentially a shallowly attached placenta with very thin vessels to deliver oxygen to the fetus. So it's not surprising that we see delivery of these placentas are tiny, they're calcified. So that is going on really at the asymptomatic level. And then you get widespread multi-system disorder that happens. That's the symptomatic part that we see in the maternal side. And that's one of the areas that is really being researched and what is happening from the fetal side to the maternal side that's starting this symptomatic process. So we believe it's these unknown factors, which I'll touch on in a few moments to discuss what's happening at the placental level and how it's activating the endothelial cells on the maternal level. So this is just to go over, make the point that this is a multi-system disorder. So we have the cartoon of the placental ischemia. See, it's going down and affecting cytokines, inflammation, coagulation, activation. All of that is just to give you a sense of all the different areas that, one, are not only being researched, but are also affected. And so you can see why we haven't figured out at this point what causes it and figured out a cure or treatment. So let's dig a little bit deeper, because what we care about and what affects us in our care of these patients is the endothelial dysfunction that we see, the hypertension, the eclampsia, the multi-system effects. And that's basically a cartoon here describing all these factors that cause this placental dysfunction. Then I'm going to touch on this and highlight this, these anti-angiogenic factors, this sFlt and soluble endoglin. Okay, those are what we think, and we have some good evidence that they're what is floating in, activating the endothelial cell. Plus, we have this part that I mentioned earlier, maternal susceptibility, so diabetes, chronic hypertension, obesity. That affects the endothelial cell of the maternal side, and that's when we get all of these symptoms. So again, just to dig a little bit deeper, because this will make sense when we review one of our studies looking at prediction. So this is a normal endothelial cell. This is outside the cell, inside the cell. And you have these factors, this endoglin that's attached to the endothelial cell, and you have FLT1, which is attached. What they believe is, and what they found in a group in Beth Israel, is that the preeclampsia placenta releases soluble endoglin and S-FLT. Those get released, and instead of TGF-beta1 binding, as it should, to these receptors, and VEGF binding to the FLT1 receptor, they're actually taken up and they're not allowed to bind, and you don't get endothelial relaxation. In fact, you get dysfunction. So going on with that, you can see that we're going to talk about these in two diseases. There's the early onset and the late onset. And this is actually one of the editorials that was done by a leading researcher who spent his entire career looking at this, said maybe the reason we're not finding out a diagnosis and we're not finding out treatment for this is because we're looking at a big group of multi-different diseases, and early, late, we see it in so many different factors. Let's separate them out. Let's look at early, let's look at late. And what I mean by early onset is the preterm preeclamptic, so before 34 weeks, and let's look at the late onset, so the term preeclamptic. And there's that gray zone that we'll talk about in these studies, the 34 to 36 week, which is the gray zone, and what do we do with that? So a couple of things to note about early onset preeclampsia to make the case that it's different. It's got 8 times more likelihood, the patients that have that, to have cardiovascular morbidity than women with normal pregnancy. Recurrence with the following pregnancy is 60% with those who have had early onset with their first pregnancy. And then the other thing, the anti-angiogenic factors that I mentioned in that cartoon, the S-FLT and the soluble endoglin, those are actually better predictors for early onset. The other thing to note is IUGR is seen with early onset, and it's also interesting if you think back, when is the last time you saw someone with early onset preeclampsia or preterm preeclampsia that's had mild? It's always severe. So these patients are sicker. They're sicker, whatever is happening is affecting them earlier in their pregnancy. Let's contrast that with the late onset preeclampsia. They have still a higher risk of cardiovascular morbidity, but it's not as high. They do have some recurrence, but again, 10 to 20% with their subsequent pregnancy. And late onset's not associated with IUGR. It's actually, they see higher birth rates. And in that case, you can have mild or you can have severe. So with that, how can we predict who's going to get preeclampsia, who's going to get early onset, who's going to get late onset? Well, lots of work has been done in that, and I'm going to try to simplify it in a couple slides. The biochemical markers that they put together in an algorithm that show that they're good predictors are this S-FLT. And I showed you that diagram to kind of make sense mechanistically. And the placental growth factor, they do a ratio. In addition, with soluble endoglin, those angiogenic factors can help predict who is going to get preeclampsia. Also PAP-A, and the great thing about PAP-A is everybody's getting that early screen. So you see decreased levels in normal chromosomes, and you see this placental protein 13, which is basically produced by placental trophoblast cells, and then inhibin A, which is increased in preeclampsia. They put those biochemical markers together with ultrasound, and you get a uterine artery perfusion index. And so just to kind of put up, there's 3 mathematical models that actually put a combination of those biochemical markers that I mentioned with the ultrasound. And they found that actually they can predict early onset better than late onset, because we know the angiogenic factors are more important in that. The prediction actually can happen as early as 11 to 13 weeks, 6 days. And what they put together is those factors I mentioned And I'm just going to give you part of the best algorithms. You could see early onset rates of 100% with a false positive 10% to 91% with a false positive of 5%. That's for early onset. Now here you can clearly see the difference if they put all preeclamptic. So the late onset, early onset, you're getting 68% with a false positive of 5 down to 44. Sorry, it should be 5%, not 55. Okay. So clearly we can predict it at, or getting better at predicting it early on in the first trimester to second trimester. But the question really is, what are we going to do with it? Because we don't have any treatment for it. So we can just tell somebody, well, we're worried that you're going to get preeclampsia. We'll monitor you, but there's really no treatment. We'll just watch you carefully. And then once somebody starts to develop signs of preeclampsia, let's say, for example, they have elevated blood pressure. How many times have you seen that in practice? Well, we have this patient, we're worried, she has elevated blood pressures. We did a urine dip where we don't know if she's got preeclampsia, but we're gonna do a 24-hour urine protein. Well, that's a long time. They gotta manage that patient for 24 hours, admit them, decide what they're gonna do. Does this patient have preeclampsia or not? In the meantime, you know, they could get sicker. So that same group from Beth Israel decided to look at these angiogenic factors and figuring out, once a patient starts to present with the signs and symptoms of preeclampsia, if we looked at their S-FLT and placental growth factor together as a ratio, would that help us predict in the next 48 hours that this patient is going to get sicker? Getting sicker meaning more elevated blood pressures, platelets are going to start dropping, liver function tests are going to start dropping. So they did this, and it should note that the kit that they use to get S-FLT and placental growth factor, it's pretty easy to do in a lab, and it's not commercially available that I have found in the United States, but apparently they have one, I believe it's Germany, that has a more commercial kit. So these were sent out to a group that does it in Europe. And so what they found was the blood pressure plus proteinuria plus this, this is the S/P, is the S-FLT placental growth factor, basically was a good predictor. And if you add uric acid, it's also good, but really your money is putting these factors together, and that will predict, you know, who is going to get worsening symptoms. The reason they were interested in looking at this is that gray area that I mentioned, that 34 to 36 week group, that patient that doesn't quite have proteinuria yet, and you know, they have elevated blood pressures, the one they're calling gestational hypertension but not preeclampsia, or the severe gestational hypertension. So what do we do with those patients? So everybody wants to know, are they going to go on to become sicker in the next 48 hours? Are they going to develop preeclampsia? Should I induce them? What should we do? So this actually was done to sort of help get at that gray area group. The problem with the angiogenic factors, the S-FLT and the placental growth factor and soluble endoglin, as I mentioned before, they're better in early onset. And so you start to see the levels rising. And so it's not entirely the best predictor for these sort of gray zone areas. It does help a little bit. So again, we still have a little bit more to do, and it's not sort of the best for that gray zone group. So just to show you, this is the receiver operator curve to show you what the S-FLT and the placental growth ratio there. Clearly on this receiver operator curve, here is the reference range, and you can see that that's actually the best. And this study, they looked at basically under 34 weeks, and then they were looking at above 34 weeks, so they could compare those groups. So, which brings us to, can we come up with something different and something that we know we can get lab values for, we can get you know, blood pressure, something that we have routinely available to us that we don't have to send out for a special test. So this study was done in the Lancet. It was called the full Piers model. It was a multi-center trial and enrolled, as you can see, over 2,000 people. And it was designed to predict maternal mortality of preeclamptic patients and what adverse outcomes could we predict in the next 48 hours and then 7 days after admission. What they actually found was, as you can see there, those predictors down here is what fell out. Interestingly, I'd like to point out that some of them are part of the criteria for preeclampsia, but some of them aren't. And some things like chest pain and dyspnea, I have to say that our obstetricians aren't asking about that specifically. And this is oxygen saturation, is actually room air oxygen saturation. But those were the factors that actually showed that they could predict what adverse outcomes. And when I say adverse outcomes, things that we would care about: eclamptic seizures, stroke, pulmonary edema, requiring increasing amounts of oxygenation, low platelets, and they used down to 50,000. So they came up with this calculator, which I put this up here so that you guys could pull it. You can just type in this, we'll pull up, it'll take you to the website, and on the website it gives you all of the things that they were looking at for the risks, and it actually lets you put in the values and calculate your probability of having this mortality event or morbidity event in the next 48 hours to 7 days. So I did it. Hopefully this will come up. Didn't show as well. I played around. This is what the website looks like. So I played around here, and you can see I made everything similar, but I had here the dyspnea, no, and then I did dyspnea, yes, and you can see right here the probability. So it's kind of fun. I do this with the residents when we have a patient that rolls in, and I say, okay, we don't know what to do with her. We're going to watch her. So I said, well, let's put her on the calculator and calculate what the risk of having an adverse outcome in the next 48 hours. And we plug it in. Things that really make a difference, obviously, is dyspnea. So it begs the question that maybe our obstetricians and we should start asking that question. And then also the oxygen saturation, if you manipulate that, also you can see big changes. So again, this is not going to help us with the patient that has severe preeclampsia, that's has HELLP. They're gonna move to deliver that patient. We know that patient's gonna get sicker. It's gonna be those patients that are in that gray zone. That what do we do? How should we should we induce them? Should we watch them? What are we worried about? So this calculator works pretty well. It was actually just validated in another study with the same group, because one of the comments and limitations of it was they took data starting at the time of admission, but continued to add data to the model for the first 24 hours. So what people had said was, well, what if you just took baseline once they were admitted? So they validated that. They repeated the study. They just took admission data, and they found that although the receiver operator curve goes down a touch, it's still in sort of the low 80s, 0.88 for the receiver operator curve number, still reasonable and definitely something better than what we have had before this. So I would encourage you guys to go on the website, take a look, and play around with the calculator. We all love calculators. It's only a matter of time before there'll be an app. I'm sure there's going to be an app with that. So where are our management changes? This is important for us because we're going to see these patients. It's the severe preeclamptic patients where we're now seeing ACOG has taken a statement about stricter blood pressure control. And I'm also going to bring up the mag sulfate for neuroprotection, which sounds like a strange thing to add into a preeclamptic talk because many of our patients are on mag sulfate for eclampsia. But I just want to point out the issue of during delivery. The use of using mag sulfate at the time of delivery, especially that goes into when we're doing C-sections. So we'll talk about these two topics. So why the stricter blood pressure control? Well, looking back in the data, 2/3 of the maternal deaths in the UK were from cerebral hemorrhage or infarction. In the recent US case series, they actually took 28 patients with severe preeclampsia, and 54% of them died, and all but one had a systolic blood pressure greater than 160. What it's been found is that we're doing great with using mag sulfate for eclamptic seizure prevention, but we're letting the patients have blood pressures going way over 160 in the 200s, and they're stroking. And so we really want to prevent this from happening. This was a patient that delivered at she was deceased, and I don't know the details if she delivered or before or after this happened, but she had severe preeclampsia and suffered a stroke from her pressures being too elevated. So this is a reminder that we need to do a better job at controlling our blood pressures. And so this is what ACOG came up with. The physician must be notified that the blood pressure is greater than or equal to 160, or the diastolic blood pressure is greater than or equal to 110. If it's persistent for 15 minutes, they want you to do fetal surveillance at that point. So they're requiring the nurses to put the baby on the monitor, and then administer antihypertensives. There are two choices. You can use either one, labetalol or hydralazine, as your first line. And you repeat the blood pressure in 10 minutes. If you're still at that elevated blood pressure, then you need to double your initial dose, whatever you decided on, labetalol or hydralazine, okay? Now let's move to neuroprotection. So there was a seminal article in the New England Journal in 2008, which basically was looking at mag sulfate versus placebo for controlling these early deliveries, and we're talking 24 weeks up to 31 weeks for prevention of cerebral palsy. The primary outcome, which was a composite of severe or moderate cerebral palsy and death, was not significant, but what actually came out as significant was the secondary outcome of moderate or severe cerebral palsy. It occurred less frequently in the mag sulfate group. And in that study, they actually did a 6-gram load with 2 grams an hour, similar to what the obstetricians do for preterm labor prevention. And the key with this was that you wanted to do it when delivery was anticipated in 2 to 24 hours. So I'll show you, this was the outcomes at the follow-up. And I'll blow this up for you. Here's the key parts. So this was the composite, which was the primary outcome. This was just the moderate or severe cerebral palsy alone, so significant. And then this is without major congenital anomalies. These were all pregnancies. This is without. So because of this article, several follow-up studies were done, and that prompted a Cochrane review, which basically showed that, yes, this has some potential. We're not sure the mechanism, but it should be considered. And at our institution, actually, for anybody that's under 31 weeks or 31 weeks or under, they're getting MAG for neuroprotection for the fetus. And so that is the patients that we have preeclampsia that they're trying to expectantly manage that are preterm. They put them on MAG, they make sure they have them on MAG at least 2 hours before they're going to do the C-section, and they want the MAG to be continued during the C-section. So ACOG gave these guidelines, and they sort of didn't make it definitive, but as you can see, they do say that there's evidence to suggest that, and it's something for the obstetricians to consider. And MAG for us during C-section is really important for hemorrhage, safety concerns. So this is something that if your institutions aren't doing it, you may start to see this happening. So now for the switching over to prevention. So I talked about ways that we can predict, algorithms to use, ways to figure out risk stratify who's going to get an adverse outcome. But what about prevention? What trials are going on? So there's the STAMP trial. Every trial has to have an interesting name and title. And this is basically showing the proof of principle. It's a double-blind, randomized controlled placebo trial looking at several different centers in the UK to have patients start pravastatin and to see if that helps with early onset preeclampsia. So what they're doing is they're taking patients who come in who meet the criteria for preeclampsia, so they're 24 weeks and beyond is when they would start them on this trial. They consent them, they decide, you have by their best clinical guidelines with the PIs at each center, if they do in fact meet that criteria for preeclampsia. They randomize them and they take the statins, and then they look basically how long before they have to be delivered, or various outcomes of worsening blood pressures, laboratory values, and then they look at how long they got out of the time while they were on the statins. And this trial is still enrolling right now. So where we're at now is I think they need 128 patients. They have at all sites, and I just checked today, 33 patients have been enrolled. So we're still a ways away from getting the results of it, but it does sound like it's a potential promising trial and something to be looking at. I looked at statins for pregnancy, and obviously we don't use it in the first trimester because we're worried about teratogenicity, and so this study is started in the 24 weeks is when you can enroll in this study. So they're collecting safety data as well. So the Lampat trial. So where has this gone? So this was a trial that was huge trial that was going to try to enroll over 4,000 people. It was basically going to randomize into labetalol versus mag sulfate for prevention of eclampsia. Again, another multi-center trial. It was going on and on and on, and the primary outcome was to see if they would look at the seizure after enrollment in the study to see if labetalol was any better than mag sulfate. And they had a bunch of secondary outcomes, maternal and fetal. Well, the enrollment was suspended in 2011, so I inquired more to why that was. And it turns out that this was primary out of Utah, and the maternal fetal PI that was under this trial actually relocated to a hospital in Texas, and he's a division director there and has established it, but hasn't restarted this trial, and I don't know if it will. I wonder if, based on the mag sulfate issue in neuroprotection, if it will continue, because if neuroprotection, if we're going to be putting these patients on for fetal neuroprotection, maybe nobody is going to want to be enrolled in that trial. So we'll see. I keep checking to see if they've started re-enrolling, but haven't yet. So I'm going to talk about this last few slides are really about the risk after pregnancy. So when I trained in obstetrics, the teaching was always deliver the mom, she's cured from preeclampsia. She may have it with her next pregnancy, but she's cured. That's actually, as we're finding, not entirely true. So looking at prospective and retrospective cohorts and in meta-analysis, they've actually found that you can see these various cardiovascular diseases after delivery, and this is the after delivery, the patients that had preeclampsia, and this is all comers, these are the early and late onset preeclampsia, have much higher risks for cardiovascular disease. And this mortality, 1.5 times at almost 15 years. And so the issue is that these women are not actually cured. They obviously have suffered something that continues to follow them throughout their lifetime. And again, we'll follow them with their pregnancies, but also follow them. And I think that for every surgery that we look at, maybe we should be asking not just if a patient is coming in for a routine surgery, do they have diabetes, do they have high blood pressure? Maybe we should be asking them, do they have they had preeclampsia with their pregnancies? So where we are with the future, we really need to understand a better mechanistic, what's going on in early onset versus late onset preeclampsia. We need to come up with treatment strategies as we're getting better at predicting in the early second trimester who's got preeclampsia, who's at risk for it, who should we follow up closely. We really should have an alternative of, we're going to follow you, but we also would like to treat, have some treatment for them. And then currently, really all we have is epidemiologic data for long-term maternal outcomes. We need to focus on what is happening with these women afterwards and what can we do for preventing their cardiovascular risks later on. And if we can understand those, the mechanism to that, we might be able to develop some treatments for them, which actually might start in pregnancy and prolong their pregnancy and prevent the further cardiovascular risks. That's it. Thank you.